Good morning, everyone. So today I'm going to be presenting my report on the effectiveness of the Defocus incorporated multiple segments lenses in myopia in Indian children. I have no financial disclosures. So the DIMS lenses are actually lenses that have a central 9 mm clear zone followed by a periphery of around 400 multiple defocus segments, which are plus 3.5 diopters in refractive error and refractive power, and they actually create a myopic defocus on the retina, correcting or preserving the myopic progression. So how they work is the myopic eye is found to be more steep in the posterior pole as compared to the periphery. Thereby, a single vision lens may only correct the posterior pole, whereas create a hyperopic defocus in the mid-periphery. By creating a myopic defocus, these lenses actually correct the image onto the retina, thereby providing a clear image. And that's how they work. Now, the pros of these lenses are they are non-invasive, they are comfortable, they have good compliance because the child is anyway wearing the glasses, and they can be used for pre-myopes as well. Now, the purpose of our study was to have the clinical short-term effectiveness based on the cycloplegic refraction and the axial length. We included children who were 7 to 17 years with progressive myopia. Children's refraction ranged between 0.5 diopter to 9 diopters with astigmatism less than 1.5 diopters, and children who did not have any previous experience of myopia strategies. We excluded children who had strabismus and binocular vision abnormalities or any other ocular abnormalities. So the children, this was an 18-month study. We included 50 children with 100 eyes with an informed consent from the parents. The children were monitored over 4 visits. The first was the baseline visit, second was V1, V2 and V3. Baseline visit, all the children were given single vision glasses and followed up for a period of 6 months. At 6 months, that was the V1 visit, they were divided into 2 groups, the control group who continued to wear the single vision glasses and the study group who were then shifted to the DIMS lenses. The second, these 2 groups were then followed up for 6 months and then 1 year. At every visit, the axial length and the cycloplegic refraction was measured. These were the results. Between the controls and the DIMS, we can see the mean age was 10.5 and 10.8. The mean refractive error was minus 2.9 in the controls and minus 4.2 in the DIMS. The mean axial length was 24.2 and 24.9 in the 2 groups respectively. So when we come to the comparison of the refractive error, we can see that from baseline to V1, in both the controls as well as the study subjects, the mean progression was 0.76 diopters, and in the study subjects was minus 0.8 diopters, so pretty much similar. This was statistically insignificant. When they were followed up for a period of 6 months, the study subjects showed a mean progression of minus 0.16 diopters, plus or minus 0.2 diopters, and over a period of 1 year, it was minus 0.24 diopters plus or minus 0.2 diopters. As compared to the control subjects, at the end of 1 year, they had a progression of minus 0.7 diopters. Now, the difference between these 2 groups at the end of 1 year was minus 0.46 diopters, and the refractive error control was 65.7%. So this is the axial length. Sorry. Yeah, with regards to the axial length, 0.29 and 0.33 at the V1 visit, and at the end of 1 year, 0.3 and 0.13 was the thing. The difference between the 2 groups was 0.17 mm, which was statistically significant. The control in the axial length was 56.7%. The change in the absolute change in the refractive error over 1 year, this is the blue is the control group, the orange is the DIMS group. We can see that this is the number of subjects and this is the absolute change. We can see that 16 subjects had 0 diopters of change as compared to 4 in the control group, and 0.25, 19 subjects versus 10, 0.5 diopters, 12 versus 8, and we can see that none of the patients had more than 0.75 diopters in the study group. Overall, we found that 94% of the children with DIMS had progression of less or more equal to 0.5 diopters at the end of 1 year. These were the changes. We did find that 3 children did not have any effect on progression, that was 12%. So the discussion, refractive error was slowed by 0.46 diopters in 1 year, axial length by 0.17. The effect of DIMS was more robust in the first 6 months. 32% had no progression in the DIMS group and 50% had 0.25 or less. We also found 28% of controls did not progress, which gives us reason to believe that we should wait for 6 months before starting myopia control strategy. When we looked at the other studies, the Lam et al. Study was done for 2 years, which was the initial study, and we could find that it was comparable to the Lam study. The strengths of our study was that we had a control group, we also had a self-control group, and we started them only on children who were on progressive myopia. The limitation was the sample size, the short follow-up, and we did not measure relative peripheral refraction, and we did not also see the rebound phenomenon. So this is my conclusion slide. We can see the statistically significant control of 0.46 in 1 year and 0.017 millimeter in 1 year. Thank you. Yes, ma'am. So we did not
DIMS without doing peripheral refraction.
Yes, ma'am. So for both controls and DIMS, this was done, I think we started at 18 months, so this was almost 2 years back.
Sure.
So at that time, we started them without checking the peripheral hyperopic refraction.
Okay. So by checking the peripheral refraction, how would you have differed in your...
What we did, ma'am, 3 children did not respond.
Yes.
So though I cannot comment on the others because we have not followed all of them yet,
Yes.
the 3 children who did not respond, we did check their refraction. They had peripheral myopic defocus.
Okay.
So that was done as an afterthought because they did
Yes.
not respond to the, did not completely respond to the,
Yes.
the spectacle at all. So,
Sure.
So that was one of the
That would
limitations.
be a limitation,
yes,
isn't it? So
that
you
is
should have mentioned that.
I did mention that, ma'am. It was there.
One thing more. Now, initially we go by definition, then there should not be any anatomical or physiological something like error. So did you check corneas?
Yes, sir. So the initial inclusion, we excluded all children who had any other ocular or systemic abnormalities.
These also higher order aberrations, or for that did you check?
Sir, all children underwent topography. That's part of the myopia workup. So if there was anything...
Have you analyzed that data?
Sir, we excluded the children who did not, we did not do an aberrometry, sir. We did a topography.
Suppose cornea is clear, but
Yes, sir.
on the surface there is something. Why I am asking again and again?
Yes, sir.
After the refractive surgery, we are seeing then patients who are having, even of 40 age, who are having the laser for the higher order. Their initial vision is 6 to 18 or 20, and they are improving to 6.9.
Yes.
Or sometimes there is one surgeon who claim that after putting cataract surgery, patient again come to the 6/6. So my point is that looking for the cornea and other things. So the retina, or initially we used to thought or teach that at that time only retina is responsible. From this decade only corneal research has come, and now we have so many parameters.
Yes, sir. I agree, sir. Sorry, we did not see the aberration, but for these profiles for these patients.
Thank you so much.
Thank you.